spread the virus. Yeah, even you can be carrier and you don't know it because you have no symptoms. You should wear a mask. And in countries where they are very strict with that, they doesn't have so high impact of the virus.
So we can go ahead. We are live.
Yes. Good evening, friends. Welcome to the Pediatric Orthopedic Society of India 24th webinar. Today we are really fortunate to have Professor Michael Weber from Germany and Dubai with us. And he's an eminent faculty on the management of tibial hemimelia. Before I invite him for his talk, I would like to give a short introduction. Professor Michael Weber has started his practice in Germany, and before 11 years, he was at University Hospital of Aachen in Germany. Then he migrated to UAE, and then he started his Center of Excellence for Limb Lengthening and Limb Reconstruction in Dubai. He is very famous for his classification of tibial hemimelia. And whenever I ask that Professor Weber is coming, everyone says the Professor Weber of the one who has described the classification of tibial hemimelia. Yes, he is with us today. The most important thing is he has 30 innovative techniques which he has described, and one of the major goal of his reconstructive surgery is to avoid amputation in this condition. In addition to that, he has 130 scientific publications, 5 book chapters, and naturally when you are so innovative, people always invite you, and he has given more than 530 lectures all over the world. Today he's with us. So Professor Weber, now it's all yours. Thank you.
Yeah, thank you very much. How do I get back to the...
Yeah, I will stop sharing.
Yeah. I should share screen now?
Yes, yeah.
Okay. So you can see my presentation?
Yes.
Okay, today I will talk about transformation and booster surgery in tibial hemimelia. What this means, I will explain soon. Before we start this, we have to ask ourselves, why shall we reconstruct is the wrong word, I said it already, construct a lower limb. Before we answer this question, we should have a look what are the alternatives to treat the tibial hemimelia. Of course, we have the orthotic devices, which are very useful and which are still using before and after the surgery. But I think we can do better. Let's have a look what this nice guy has to show us. Former governor in America. He's doing a kind of surgery on his arm. And he's exposing a tool, yeah, which is very interesting. There's obviously a super function.
Listen to me very carefully.
Yeah, listen to me. Unfortunately, this tool is only reality in Hollywood, so we cannot use it. So, and therefore, in my opinion, the natural limb is best. And I like to show you my techniques to improve the function and to prevent amputation in children. What is needed? First of all, growth. In children, we have a lot of growth by the children himself, but we have to add also growth. We do this in form of callus destruction. You need hardware. Which one? I prefer rings, not this one, but this one. I still use the Ilisarov frame, mini fixator and maxi fixator. I met Ilisarov personally, that's me. In Kurgan in 1990, it was a very impressive visit. He was a magician on his field, and I tried very much to learn from him. And of course, I met Taylor a couple of years later, and I use his head support till now. Only Mr. 8-Blade I haven't met yet. I see when I meet him. I use the different tools all together. I use the advantages and combine them. For example, here, a patient I treated here in Dubai. This is a patient with a type 3B. So you see here, this is the end of the tibia piercing out of the skin. And what you see here is that I have mounted a core with the Ilisarov ring. And around this, I have the talar spatial frame. So I use the talar spatial frame to do all the corrections. And I use the Ilisarov frame to mount closely to the leg. And once the correction is made, I remove the talar frame. And then I immediately can do the range of motion of the knee and all this. And the whole thing is more slimmer and the patient can walk on it. So for as soon as possible, post removal of the talar frame, the improvement of the range of motion of the constructed knee or ankle. Of course, you need deformity planning. This is what we have to do in all of the cases, not only tibial and hemimelia. What I'm doing very much is I prepare each case very thoroughly. And I do for each of the case MRI to detect if there is a cartilaginous Anlage or not. I will show you later in my presentation. And of course, you need some good ideas. So as I said already, we are not talking about reconstruction, we are talking about construction. That means these surgeries are producing something new, not repairing something in the way which was it before. So, and as you know it also from motoric replacement surgery, you know it from callus destruction, this is construction. I want to introduce you to some new words, booster surgery and transformation surgery of mine, and what does this means for the construction of joints and limbs in tibial hemimelia. Here, this is my classification, which I published in 2008. There are 7 different types. Let's go step by step. Type 1 is the hypoplasia. Hypoplasia means that the tibia is completely there with both joints, ankle and knee joint. It's only hypoplastic. The type 2 is the diastasis, means the tibia is there, of course fibula is there, and usually the foot is in between both bones. This is a diastasis of these both bones. And you can have all different kind of modifications of that. The foot can be here, it can be here, the foot can be twisted, it can be a clubfoot situation. But these different phenotypes are phenotypes. They can be all reduced to this picture of a diastasis. If you go to the aplasia, as you see here, the distal part of the tibia is missing. And this is also a term aplasia. Aplasia always means a partially defect of an organ. So the partially defect is here distally. And you can have all different amounts of defects. So it can be like this or like this, the defect, or you have only a little bit of the proximal epiphysis left over. It's still a distal aplasia. And you can group them like this. Yeah, there are so many different phenotypes of this. It doesn't make sense to create for every tibial hemimelia you see in your clinic a different type. These are the principles of the preaxial longitudinal deficiency called tibial hemimelia. And you can have it, the aplasia, the partially missing of the tibia proximally. You can have it proximal and distal, it's called bifocal. You can have a total lack of the tibia with double fibula, and you can have the total lack of the fibula called agenesia. This is the proper term for it. Agenesia means an organ is missing. And here the tibia is missing completely. So this classification represents, and this is the only classification worldwide, which represents the pathological anatomy, the process of the preaxial longitudinal reduction deficiency. The process how the tibial hemimelia occurs and develops. So another important point of my classification is the cartilaginous Anlage. all the type A's, type 3A, 4A, 5A, 6A, 7A, have cartilaginous Anlage. And I was the first who described the existence of the cartilaginous Anlage. And this is super important because with this cartilaginous Anlage, you can do a lot of good things. And of course, you have all type B, 3 to 7B, where there is no cartilaginous Anlage. What is important that all these 12 different types need different surgical approaches. They're all different, okay? And what is also important is that from type 1 to type 7, the difficulty for the surgery increases. Yeah, so you have to do more and more and more. And therefore also the result can be poorer than the treatment in type 2, for example. But I can show you very, very good results even in the worst case scenario, type 7B. Okay, here's the classification in comparison with other classifications. Kalamch and Dava I have skipped here. It's all the same. You can see here on the different colors and all the different lines. This is my classification. And if you compare it with those of Jones and of Paley, all the white areas are the areas where they don't have these types. So this is not existing for them. And what I see also, what the colleagues are doing is that they give different phenotypes of the tibial hemimelia an own type. And from my point of view, this doesn't make so much sense. For example, if you have a diastasis, as I said, the foot can be in different orientation. It doesn't make sense to make a new type if the foot is more into the gap, or if the tibia is piercing through the skin. It's all a diastasis. So otherwise, you know, I have nearly over 200 limbs treated. Nearly every limb is different. So my classification reduces all the different phenotypes to the main pathological anatomical process. And they need to have different surgical approaches. All the other things are phenotypical and doesn't make sense to put it into own type. I don't want to go too much in detail with this. You want to see how I do the surgery. So the advantages of the Weber classification, it's precise. All the pathological anatomical definitions are used correctly. You read quite often total or complete aplasia. This is a wrong term. Aplasia is always partially. You cannot have a total partially. This is not working. This is agenesia. As I said, it represents the pathology of the preaxial longitudinal reduction deficiency. Fibular hemimelia, for example, would be postaxial. The main types are included. No typing of symptoms of the tibial hemimelia. Correlation to the severity of the disease. The very much importance of the cartilaginous Anlage is respected, and it's easy to use it clinically. And for those who are more interested to compare also the cases to each other, I have created a score where the joints of femur, foot, hip, and so on, and the muscle function are included. Don't get disturbed, it looks a little bit complicated, but it's only a checklist. Yeah? So you get here different points according to the hip, the femur, the patella, the tibia, according to my classification. What is wrong with the fibula, with the foot, and the muscle function. It's very simple. For the muscle function, not 5 different types, only 3 types. Is there a muscle function? Is the function partially absent, or it's completely absent? This is completely enough to get a score. And here you have different groups, actually 5 different classes. The best is 1+, and the worst is 5-. Yeah? And if you have different therapeutical approaches and you use my score, you can say, okay, we have the same base, the same structural problems of our cases. Now we can see who is better. but a lot of surgeons don't like to compare their cases, I can tell. Okay, let's summarize. The Weber classification and score system is a simple and therapeutic relevant classification with the main different types. It represents the pathology of the preaxial longitudinal reduction deficiency, respects the importance of the cartilaginous Anlage, and gives a scientific comparison of the different pattern of the defects between different authors. Here, this was a statistic I made a long time before. The statistic and the distribution of the different types haven't changed so much. Most are the severe cases. Also 3B and 4A are quite common, 1 and 2 as well. And the others are more rarer in this condition. Let's have a look to the booster surgery. So what do I mean with the booster surgery in tibial hemimelia? It means the use of the cartilaginous Anlage is a real breakthrough in joint construction. All these types, 3A, 4A, 5A, 6A, and 7A have a cartilaginous Anlage. And this extraordinary finding enables the booster surgery. So the motto of treatment: enhance the sleeping growth potential of this cartilaginous Anlage. And you will be surprised what you get. Let's start with this type 3A. This is, as you see here, distal aplasia with the cartilaginous Anlage. Here you have the MRI of it. Here this is the bone, and this is cartilaginous Anlage. Okay, this is the patient I have treated. You see here on the left side, distal, in the X-ray, the distal part of the tibia can't be seen. There's a defect, obviously, in the X-ray, and there's a bowing of the fibula. You quite often see that. Yeah? And look at this maturation. What is the reason for this maturation? It's the same patient. There is something different, because normally these type of leaks develop like this if you do nothing. You will get a bowing of the fibula, you will get a hyperplasia of the fibula because the patients are walking on it, because the tibia is hypoplastic, because the distal part is missing. They have no contact to the weight bearing, and this tibia gets hypoplastic and hypoplastic at all. It shrinks, so to speak. So what is the difference, how it comes to this maturation? Is it possible, by the way, can I, 1 second? Good, I find how to do it. So what is the reason that this end up in this? I did something. So what did I do? This is the cartilaginous Anlage, the schematic drawing, the cap. I did a cut into the bony area. And then I did a lengthening of the bony area. This is a segment transport to distally, until the cartilaginous Anlage of the distal tibia came into contact with its joint partner talus. And then look what you get. Yeah? So we start here, and we end up in a tibia looking nearly like a normal tibia, and even with the own growth plate. Not only that, without having done any osteotomy, correction osteotomy of the fibula, only by the destruction stress of the tibia, the fibula becomes straightened out. And this is what I call booster effect. Everything is there, even the growth plate. You only have to bring the cartilaginous Anlage of the distal tibia into contact with the joint partner, and with the effect of the callus distraction and all the growth factors which are stimulated and distributed over the body when you do a callus distraction, and with the postoperative weight load on this tibia, you get a maturation to a nearly normal tibia with own growth. So this is on the left side. This is actually my hero. You see here all 4 extremities are affected. I have done already a surgery on the right side. I will explain later what I have done there. Let's focus on the left leg. He needs to have orthotic devices. And 7 months after removal of the fixator, I was able to play soccer. Let's have a look into the biterminal or bifocal aplasia of the tibia. And this is a schematic drawing. We have a cartilaginous Anlage here and here. This is the tibia with the adjacent cartilaginous Anlage. You see here distally is a gap, but not proximal. Why? It depends when you get these children. If you get them from the birth, you will see that there is usually a gap. But when they start walking on it, they walk until the fibula gets bent, then the fibula becomes stronger and stops from the tibia from getting in contact. So the tibia got into contact with the knee joint because of this weight load. So don't worry about this. In fact, there is a gap which has to be closed because we have a relative overlength of the fibula. There is not like some others are postulating in their classification, an overgrowth. There is never overgrowth of the tibia, of the fibula, except the patients are walking on it. When they come to birth, the fibula has the normal length, and what is the difference is the undergrowth, is the diminished growth of the tibia. So it's a relation problem, but there's never overgrowth from birth. It's also very important. This is to understand the pathological anatomy of the longitudinal reduction deficiency. If there's any problem with the fibula, it's called post-axial longitudinal deficiency. And then we have the fibula hemimelia. But there is no overgrowth. The overgrowth is a phenotype. It's due to the children walking on it. Very important. As you see here, class 2. Although this is why Weber type 5, it has class 2. Class 1 is the best. Class 2 is not so bad, actually. Why is that? It's because of the cartilaginous Anlage. This gives us huge options to create joints. And as you expect, you have the gaps here. We do a bifocal segment transport until the proximal cartilaginous Anlage of the tibia is in contact with the femoral condyle and the distal part in contact with the talus, and then you get this result. And I can show you how the intraoperative looks like. Mini ring fixator applied. And here with the smallest chisel I had, I did a cut into the bony area, then I did the lengthening. You see the femur is also attached in the first place. You do the contact and then a continuous lengthening until you have equalized the relative overlength of the fibula. So you see here, it starts with this small gap and ends up with this big one. So a lot of lengthening done here. Very important is you need to calculate when you have the docking, because what you don't want is to smash the cartilaginous Anlage into the joint partner. Then you will destroy the cartilage. And to make sure that I have achieved my goal, I do arthrography, as you see here, for the knee joint and for the ankle joint. And this is what you have constructed. By bringing with the bifocal segment transport the cartilaginous Anlage to the joint partners, you have created a knee joint, which was not there before, and the ankle joint, which was not there before. And this is booster surgery. And how it boosters, you can see here. You get your growth plate from the cartilaginous Anlage over the time. This is the second lengthening. I don't want to achieve the whole lengthening at once. I want to take care of the cartilaginous Anlage and don't put it too much under stress. So this is the second lengthening. So you see here also the small gap here, and this is the amount of lengthening. And here the series AP and lateral pictures, AP lateral, AP lateral, AP lateral. After 2 lengthening procedures, we started with this small bone and end up with this one, 400% lengthening. You cannot do this in normal patients. You can do it only in pediatrics. And if you do a segment transport, these legs are crying for segment transport and to be treated like this. And then you end up in very nice results, construction of knees and normal functioning limbs. Let's talk about transformation surgery. What is transformation? This is transformation from a truck to a robot using the existing materials. The same we can do in orthopedic surgery for children with tibial hemimelia, also with other problems, but today we are talking only about tibial hemimelia. So what is the motto? Use the anatomical resources to create better functions. Let's start with the type 2, the easygoing case. Yeah, this is the diastasis, you see here. Class 1, this is the less difficult type. And the first procedure you have to do, you have to bring the fibula with a simple soft tissue lengthening into place. The foot into place. Yeah? You have to distract the foot from the lower leg. And then in most of the cases, you can do acute centralization of the distal tibia over the talus. You can do it acutely. In the older children, you have to do it step by step via slowly shifting it, which is also not a problem. And once you have achieved the correct position of the distal tibia to the talus, you secure your result with a plasty of syndesmosis. How to do all this, I will show you. Of course, first you have to do some soft tissue release, Achilles tendon, lengthening capsulotomy dorsomedially. You do lengthening of the flexor tendons. You have to treat, in most of the cases, the plantar aponeurosis. These are all additional procedures you have to do because all the feet in tibial hemimelia are a little bit different. Then you can combine, here this is, let's say 27 years ago, you can do some acute correction, use the Lisarov device as you see, and later if it's too much stress, continuous correction, especially of the adductors, equinus, and the telescoping of the foot for the distraction. And what is very important in all these cases, you have to be aware of the intraoperative situation. You have to be intraoperative diagnostic. Yeah? So you have to be very careful. For example, the fascia here was attached to the perichondrium and periosteum of the distal fibula. This is the cartilage of the distal tibia. And you need to prepare it because you can use it. What's also very important, in most of the cases you have anatomical variants. Yeah? Here, for example, the tibialis anterior tendon, extensor digitoris longum tendon was going through the joint. Yeah? There is no joint, but where the joint should be. Yeah? Be very careful not to cut it and to reorient the structures so that you have the proper function afterwards. And here you see that the acute reduction of the tibia to the fibula only with a clamp. Yeah? And it is secured here with the K-wire. You can see this is the K-wire, here green. This is the tibia, and this is the talus. They secure it with the intramedullary K-wire going from the plantar of the foot through the talus, through the fibula. This will be removed later. And to have a permanent reduction of this positioning, it's not a repositioning because it was never there, it's a positioning. I use then this fascia and the perichondral and periostal flap to create a syndesmosis. Here you see the periostal perichondrium and periost, the posterior one. You wrap it around the fibula, so to speak, or to the tissue, attach it to the tissue of the fibula. There's some remnants of the membrana interossea, and you combine it. So with this structure, then you have a posterior anterior flap connected to each other, and this secures, this produces a syndesmosis and secures the positioning permanently even after I've removed the K-wire. Here, this is the preoperative picture, and this is what should not be mistaken as a new type, the so-called overgrowth of the fibula. This is reactive because the child was walking on the fibula, and the fibula reacts to the weight load, you know, and the tibia was without any weight load, and that's why it's atrophied. You need to read these pictures according to the pathological anatomy. And this is after the surgery. You see the tibia orange, the fibula is yellow, and the calcaneus, a good centralization, yeah, of the situs. So this was the leg before the surgery. You see here this orthotic device, quite strange. Here the right side was already treated. And this is the postoperative outcome. You can throw away this orthotic device. It's not needed anymore. They can use normal shoes. Yeah? They don't need any orthotic devices. Let's have a look to these cases, which are difficult in order to get an ankle joint, yeah? Because all of them have no cartilaginous Anlage, as you see. And in these cases, you have to do a fibula pro tibia operation, you have to do a centralization of the foot, and you have to make the ankle stable. How to do the stabilization of the ankle? Let's start with the type 3B. As you see here, type 3B, there's only a proximal tibial Anlage. In this case, you see, this is the tibia, rest of the tibia. But it's still a distal aplasia, and look at this amount. There's no need to make another type. This is still a distal aplasia. You have so many different reductions of the tibia to make from every of those another type doesn't make sense. It's as if you have an infectious disease and every 0.5 degree change of the temperature you make a new type. Doesn't make sense. Okay, so we are talking about, and there's a club foot, a flat foot, it's rotated inwards, outward, as you like. It's a phenotype. So this is the proximal tibial Anlage, and what is the thematic to that? You have to do your lengthening to equalize the telescoping, then you do the osteosynthesis between the proximal tibial Anlage and the fibula after you have centralized the foot. So this is the picture. This is how I make the osteosynthesis. Here's a wire through the tibial Anlage, a central wire through the fibula. Of course, you have the ring fixator to ensure good stability, and this is the outcome. And you see, you get your growth plate. Not only proximally, you have it also from the fibula distally. This was preoperatively, this was postoperatively. I showed you before this, so both legs are treated properly. So what's to do with the ankle stabilization? As I said, how can we do this? Here again, a case of fibula pro tibia surgery, so to speak. I do a ligamentum cruciatum plasty to keep the fibula head in place where it should be and where it should develop a joint and centralize the foot. And I do the stabilization of the ankle joint with a periosteum flap. So you mobilize a periosteum flap and flip it towards the calcaneus. And with this, you have bilateral knee joint ankle joint stability. Let's have a look to an intraoperative view. This is the fibula here, and here this is the mobilized periosteum. And you do it from both sides. Yeah. So this is, and you bring it down to the calcaneus on both sides. Then you have your ankle stabilized. Here you see a child, 6 weeks postoperatively, 5-ray foot. These foot, I try to create a new ankle joint. So therefore I do these periostal flaps. In the smaller foot, only 2-ray, I try to do arthrodesis of the fibula and the foot. And this is 6 weeks after, and the girl will show you how she will move the new ankle joint by herself. You see here? She's doing her own physiotherapy. Yeah? You see, no pain, The child can do it easily and is even smiling while she's moving her ankle joint. This has to be built. It needs time for the distal fibula and for the foot situation to create a kind of ankle joint. But with the bilateral stabilization, you will get one. And with a fixator in place, of course. Without, it won't work. Let's come to the severe type 7B. And if you look to my score, it's not 5 minus. It's 4 minus. Why is this? This is the most severe type. It should have 5 minus. The reason why it doesn't have 5 minus is because this case has also a patella. And this patella kicks it to 4 minus, because we can do something very nice with the patella I would like to show you now. Normally, all over the world, these cases get amputated, but if you use my technique, you don't need it anymore. I published this, actually I did this case I'm showing you now 27 years ago. I published it in 2002. It was awarded from the German and European Pediatric Society, and these are cases like that, what we are talking about. You see here, there's no tibia, there's no ankle joint, there's no knee joint. The fibula is transverse under the femoral condyle, and the foot is somewhere flipping around over there, complete unstable. And you can have all different forms. The foot can be other way around and so on, and can be more straight, and the fibula can be in the back or in the front. This is not a different type, all the same type. And this is the first time that this child can walk upright with the fixator in place. And this is a status after the simple soft tissue. So, and here's my hero. As you see, my patient I have treated for the first time 27 years ago, bilateral radial clapphands, bilateral tibial hemimelia. On the left side, I've shown you already the type 3 A procedure with cartilaginous Anlage. Now I want to show you here the type 7 with the 2-ray foot. So, and to show you also the proportions, this is the fibula I'm dealing with, and this is my index finger. You see the proportions, and you will see also what it means form follows function. I come to this later. First of all, in the treatment, you need to straighten out the contractures a little bit by cast. You need to wait anyhow until the patella gets a little bit bigger so that you can use it. Then you start first with the application here with a mini ring fixator. Nowadays, I would apply over this mini ring fixator a hexapod to do all the corrections and lengthenings needed. And once achieved, I reduce it to the Elizarov core. So it's usually a lengthening of 8 centimeter, 4 centimeter at each level. And here's the trick: how to get the patella, which is already a very nice joint partner to the femoral condyle, how to use the patella as a tibial plateau. First, you have to do a secplasty of the quadriceps tendon. Then you have to do 3 incisions. The blue circle is the capsule. So 2 incisions of this capsule makes a proximal visor flap. And another incision makes a distal visor flap. Very important, don't cut this off, then you have lost. From here, the blood supply is coming, and also later the stability of the knee joint. So this is the patella. And with this visor flap, you know, from the motor helmet, the visor, you can flip it up and down. You can flip this whole structure, this whole flap with the patella down and this one up to fill the defect. And you end up with this one. You have the capsule closed. The quadriceps tendon is setplasty elongated. You have contact with the muscle, with the motor. The patella is now shifted under the femoral condyle and working as a tibial plateau. When you connect the patella to the tibia, you have a functioning lower leg, and the fibula is working as a tibia. So here you see the intraoperative picture. This is the quadriceps tendon. This is the patella. Here's the middle incision below the patella. Here's the hook under, here's the middle cut. This is the hook under the pedicle. here. Don't cut this particular blood supply comes from here and the stability. And here you can see after the shift is done, this is the former distal flap, visor flap shifted above, and this is below, quadriceps tendon. And here you have the crisscrossing of the two pedicles of both flaps. Yeah? This is very clear. Here you have the quadriceps tendon, the distal visor flap shifted proximally, the femoral condyle, and here you look for the first time at the tibial plateau, previous called patella. And this is the chondrodesis between the patella and the fibula. And how to do this chondrodesis can show you here also quick. So this is what we have. The chondrodesis, the fusion of the both cartilage part of fibula and patella, and how to get a secure connection to each other. Orange is the patella. I cut the perichondrium in an H shape and the fibula 90 degrees rotated, also in an H shape. Then you can open the perichondrium layers like a book. Let's see here, yeah. But 90 degrees rotated, and then you can connect these both together and suture this perichondrium together. And additionally, you need a wire here through the patella connected to the frame, and the whole thing will heal very nicely. What you have to do, you have to cut a little bit in a piece off from the cartilage of the patella as well as from the fibula head in order to open the capillaries so that you get a proper repair over this. And this is after everything is done, only here a little bit of gap. This has to be sutured easily to cover the femoral condyle. Here I want to show you how this visor flap is working intraoperatively. It's very important that you have the isometrical point where you start doing the incisions. If you shift too much upwards or too much distally, you might not be able to shift it as you see it like here. Yeah. So this is the shift. This was the former distal flap coming proximally, proximal flap with the quadriceps tendon, with the patella coming distally. And as I said, I use a rope here to check what is the isometrical point around the femoral condyle to have the proper radius. If you are not precise in this, the patella won't go down, may be stuck here, or you rupture the tissue. This is very important, some tricks. Okay, let's go into the schematic again. So you do lengthening, soft tissue lengthening, centralize the foot with the periost flaps, and then you put the patella, centralize, and above this you can do a cruciatumplasty. I use most often ligamentum capitis fibulae, or if there is none, you can use also the fascia or capsule tissue. And this here with the diamond hollow driller, I make my drill hole. This is the ligamentum capitis fibulae. You put it through. Here it's pulled through. This is the fibula. This is the soft tissue. This is the ligamentum capitis fibulae. And this is after you have put everything into place. This rest of the ligamentum capitis fibulae has to be attached to the to make it secure. Okay, and then also what is very important in my techniques is that I use the fixator not only to do the destruction, all this, I use also to make as soon as possible in these constructed joints range of motion. Here in this case, from the first post-operative day, I allow a certain amount of range of motion, and you can limit it here with the hinges or with locks here on the frame, which are not applied yet, to limit the range of motion in order not to have too much stress on the new constructed joint. But usually you can have full extension and 45 degrees immediately post-operatively. And you can support the physiotherapist also with rubber bands to improve the extension or the flexion. Of course, they need orthotic devices until the constructed joints have developed properly. Still, the old orthotic devices are working here with the Swiss lock. At the beginning, you lock it because they need to build up more muscle. And you see here, 27 years ago, everybody was amputating feet who have only 2 rays. And of course, the type 7B. But you see here, you can embed it in the orthotic device very easily, and they can have later, when the foot gets more hyperplastic after the weight load, nearly normal shoes. This is 1 year postoperatively, and look at my index finger. This is my index finger. And remember the fibula I showed you before. This is form follows function. Give the fibula the function of a tibia and you receive the adequate form. Within 1 year, tremendous hyperplasia. Correct axis, here's the MRI of the knee joint, of the constructed knee joint, the fibula, the femur, the quadriceps tendon inserted, as you see here, bilaterally into the patella. And here, this is the patella-fibula complex, which you cannot separate anymore. This is one structure. And this is a joint space. And this is 7 years afterwards. You see a metaphysis, you see a growth plate, proximally and distally. So it's growing on its own. Of course, not in the same speed as a fibula. So you have to do later also lengthening through this fibula. But it has its own growth. This is the function, usually up to 90 degrees or even more. Full extension is the most important. And you can see here I treat the left one in the second place. I have treated this first. You even can have full weight bearing after the procedure. This is 7.5 years after I've done the procedure of this patient. Here, as I said, this is my hero. He underwent a lot of surgeries. I know all the histories and what is involved into these cases. This was also quite interesting family history. And you see, he's better in running than in slowly walking. And he came from Austria, and from a small village in Austria, in the mountains, and unfortunately the obstetrician who gave birth to this child was telling the mother this child should have not been born. So it's unbelievable that a gynecologist made such a comment, but maybe he was completely overwhelmed of what he saw and should have not say that. But it triggered something in the mother. The mother was triggered in the way that she said, I will do everything that my child will have the best start into this world. So she was looking for an expert. She came to our center in Heidelberg, where I was working. We had a huge center there for dysmetric children. And I was also very much attacked, so to speak, by this amount of malformations. And I promised the mother that I will think about it, what we can do to prevent amputation. And I showed you the technique. So, and this is 2.5 years after the surgery, actually 7 months after removal of the fixator, is able to play soccer. 16 years later, he is a hobby-wise firefighter, and this is 25 years old. So he has studied, he becomes successful in life, and he had a super function. He can walk on his own leg with his own motoric structures, with his own muscles, with his constructed joints. Yeah? And I think this is due to the mother who did not give up despite this comment of the obstetrician. Okay, let's go to the last case. It's also strange looking situation with double fibula, and they have usually also double foot. And I was treating this case in Denmark, where the colleague has already fusioned the both feet together, and I came to treat, to construct a tibia. So, and what I did in this case, as you might expect, what works for one fibula pro tibia works also for two. Preparation of the, in this case, of the fascia as a as a cruciatumplasty, do the lengthening, bring the foot under the distal fibula and the fibula under the condyle, do anterior and posterior ligamentum cruciatumplasty, fusion at and narrowing of the foot. And then when we opened the capsule, we saw that the whole knee joint area was filled with soft tissue, a fibrous soft tissue. And instead of removing all of it, I did create menisci. Yeah, so I cut it off in the way that I will get a meniscus, and this works also very nicely. So if you look from the top of the fibula head, remove of this interposition soft tissue, and then you have your menisci produced. Yeah. And then the next step would be the anterior and the posterior cruciatumplasty. Here are the intraoperative pictures. These are the fibula head. Yeah, this is the removed tissue. These are the ligamentum cruciatum generated from the fascia, as you see here. I used the drill guide to do the drill holes, as you see here, for the anterior and posterior part. And this is the whole situation. Femoral condyle, the cruciatumplasty, the both fibula head, and here the new constructed menisci. Okay. And here also what you can do with the ring fixator very nicely, as I said before, you construct a limitation for extension. Here's now inflection and extension. Yeah? You use the threaded rods who are docking at these areas in order to limit at the first post-operative days and weeks the full range of motion. This is the view of the knee. This is the view of the foot. So the Weber transformation surgery create limbs by using the fibula as tibia, by create joints like knee and ankle by using the patella as tibial plateau, using the ligamentum capillaris fibulae or the fascia as a ligamentum cruciatum, the capsule as a meniscus, periosteal flaps as bilateral tendon for the upper ankle and for creating syndesmosis. The booster surgery create joints like knee and ankle by using the cartilaginous Anlage as a tibial plateau and tibial ankle part or plafond. Both techniques improve the function of the limbs, prevent amputations, and it's of course a domain of the pediatric orthopedics. So older the children, so less is the biological response to this technique. More augmentations, custom-made analyzers, use modern techniques like ultrasound and MRI and your precise examinations intraoperatively for analyzing the biological resources. Use the biological resources to create better functions. Form follows function. Give function to an anatomical structure and you will receive the adequate form. Give the fibula the function of a tibia and you will receive the form of a tibia. And this term comes from Walter Gropius. Walter Gropius was a very popular architect also in America. He was later in America. He was the founder of the Bauhaus in Weimar. And I would like to read to you what he wrote. He was an architect. And he wrote, "It is the law of all organic and inorganic, all physical and metaphysical, all human and superhuman things, all real manifestations of the head, heart, and soul, that life is recognizable in its expression, that form always follows function." This former architect, he knew already a lot about medicine and of nature. Aim of operation, the post-operative functional result should be better than the function of an orthoprosthesis or prosthetic fitting. This should be our aim. Don't lose time, so earlier the operation, so better the adaptive processes and functional results. And the kind of treatment should not be focused only on the operative possibilities. Doesn't mean if I can do this, the children has to underwent this. it is always important that parents and of course the patients have to be on board. If they don't want it, you cannot force it. And all the operations are nothing if you don't have a good circle of cooperation. You need all this different stuff and people and colleagues to have a good outcome. All these techniques were already published in 2007, the book from Robert Rotzbruch and Svetlana Elizarov, and later in 2015, Mehmet Kozaoglu, Hiro Tsuchiya, and Levent Eralp. And I want to show you the so-called, as I call it, Forrest Gump effect. I'm showing this also since 25 years, and I don't get tired of it, because it will let your orthopedic heart pumps higher when you see this sequence of Forrest Gump. When I saw my first hero, where I did the surgery 27 years ago, walking with locked Swiss locks of the knee, and how fast he could run in the first place, I was very amazed when I saw the Forrest Gump movie. I got immediately the comparison to it. And here is Forrest Gump. Forrest Gump is running away from the mockeries of the other children. They are chasing him, and he had this orthotic device. It was applied before, and while he was running away from them, all of a sudden the orthotic device fell off, and Forrest Gump became a fast runner, quick runner. And in former times, when I started my career and all the reconstruction of these children, especially Tibial, I was telling my audience that I wish that the children I've treated are losing their orthotic device in the same way like Forrest Gump. Meanwhile, I can say that most of the patients get rid of it. So there is an improvement of the stability of the constructed joints in a very nice way. And this gives me very great satisfaction, and I feel very blessed that I could achieve that. Thank you very much for your attention.
Yes, thank you very much. Yeah, it's a magician of the tibial hemimelia. Wonderful. Yes, Sandeep, can you?
Yes.
Yeah.
So at the outset, thank you very much, Professor Weber, for really a magical lecture and highlighting the beauty of soft tissue based reconstruction and how to convert immature cartilage into mature bone just by realigning it and using the soft tissue so that bone forms where you want, and body usually wants to correct itself. So thank you very much for that booster surgery and brilliant transformation surgery. So we have just two questions from our members, one from Dr. Jayant Sampath, who is asking at what is the earliest age at which you apply your classification? Is there an age when we can apply the classification?
The classification you can apply from birth. There is no need to wait for it. You mean the classification or the surgery?
Classification.
Yeah.
The first part of the question is, when can you apply the classification?
From the beginning.
Okay, and you need an MRI to look whether the cartilage analogy is present or not.
Exactly. Or a sonography. If you are
or a sonography,
you can do the sonography.
Okay. So it can be applied at birth also.
Of course.
Yes, and the second question is, what is your minimum age at which you will do cartilaginous lengthening and the joint construction surgery? What is the youngest age?
This is different from the different types. Let's see the severe type 7B, without cartilaginous Anlage, but with the patella. The patella needs to have a certain size, usually around 15 months after birth. They have a proper size, so you can work with it. The other cases, for example, for bifocal, the biterminal aplasia with cartilaginous Anlage, you need to have a certain nucleus of bone so that you can apply two rings and you can do a cut into the bone, you know, because you need to have the stability. And this is from case to case different, you know. So in this case, I think it was the child was 18 months.
Okay.
Yeah.
So a minimum age of about 15 to 18 months where you have adequate bone stock so that you can get your fixators on.
Don't make it so general. Yeah.
Okay.
Yeah.
Okay. But it's specific to classification.
One second. I only gave these two examples. You have to analyze your cases individually, you know.
Okay.
And if your tools you have cannot be applied because it's still too small, you have to wait. Because you cannot cut through a ossification center and you are not able to stabilize it, and you do all the procedures. So you have to analyze it exactly case by case.
All right. So it is case specific. Then the next question is, if you do not have a patella, can you just suture the extensor mechanism to the positioned fibula in the center?
Okay, this is another presentation, maybe of another 1 hour, because this is very complicated. I'm using still the same technique, not without the patella. I'm doing the cruciatumplasty to keep the fibula head under the femoral condyle. And most of these cases, they have quadriceps. And in these cases, it makes sense, but they have not the quadriceps attached to the patella because the patella is missing. So you have to bring the motor, the quadriceps, to the fibula. And you can do it also with a special technique. I mobilize the quadriceps and I do a transplant of a tendon and insert it to the fibula and apply the fixator and do the isometrical hinge to ensure that the fibula get immediate range of motion after the surgery. And what happened then is that the fibula head, as we know from the former Brown procedure, gets hypertrophied, hyperplastic. But the Brown procedure failed because Brown didn't do the cruciatumplasty and he didn't use the ring fixator. So in these cases, I would recommend to do so, and it makes sense because you have a motor in it. If you don't have it, the reconstruction is more poor. So you end up more in a stiff situation to have the fibula under the femur. And you have to decide if you want to go ahead. You have to discuss it with the parents. In some regions, especially Arabic world, they don't want to have amputations at all. But those with the muscle, they have a good chance to get a relatively good function. But it's not good as with the patella.
Okay. Have you seen that as they grow older, after you centralize the fibula, they develop progressive flexion deformity in the knee flexion contractures, which need correction subsequently?
About which type you are talking?
The 7.
Type 7 with patella or without?
Without patella.
Without patella, they are always at risk that they get contracture. You have to tell the parents that the knee joint will develop over years. And these children need to have intensive physiotherapy, and the parents need to become physiotherapists. So it's a long way to go. And if they stop doing exercises, it becomes stiff.
Have you used botulinum toxin to modulate strengths for physiotherapy to prevent contracture?
No, because it's not a problem of the muscle. It's a problem of the joint itself.
Okay.
It's not a problem of a muscle contracture. It's a problem that the constructed knee joint becomes fibrotic.
Okay. Okay. So there was one more question, repositioning of the foot to make it plantigrade. How easy is it? because people have found it difficult to put the foot under the tail, in the ankle. How do you distract it? Soft tissue. Do you find it's easy or it undercorrects?
Okay.
Especially type 2.
In type 2. Okay. Actually, this is a very easygoing procedure. It's not a repositioning because the foot was never there where it should be. It's a positioning. And what you should not do is don't forget to do all the soft tissue lengthenings, because you can do this very early in childhood, yeah, so even before they finish 1 year, because you only have to bring the foot under the tibia. And you should do a lengthening of the soft tissue. You need to use the mini fixators. And all the main structures of the foot are cartilage. And if you don't do the soft tissue lengthening of the Achilles tendon, of the flexor tendons, and so on, you end up in destroying the insertions of the tendons to the cartilage. This is a problem. Therefore, you have to do open lengthening of these tendons. And you apply the fixator on the foot in a horseshoe way. You put the fixator on the proximal tibia and you do your simple distraction. That's all. And once you have achieved the length, you do acute reposition, not reposition, now I'm saying it also wrong.
Positioning.
Acute positioning of the talus into the tibia.
Yes.
And the interesting part is that all the ligaments are still there.
Yes.
Once you have done this, you only need to wait. Of course, afterwards you have to remove the fixator. They need to have an orthotic device a little bit to cover the external force on the foot a little bit. But with the time, they all get stable.
They will get form after the function comes back.
Yes.
Okay. Thank you very much. So I think we'll move to I think Ruta Kulkarni can share her screen and show the case that she has done and get your opinion on it. Ruta, can you screen share?
Yeah. Okay, so good evening all.
Thank you very much,
Professor Weber, for an enlightening talk. I will share my experience of treating few cases of tibial hemimelia. So this girl was brought to me at the age of 2 months with such severe deformity. She had absolutely no tibia, but she had cartilaginous enlarge in the proximal tibia. The distal end of femur was normal. There was patella. The foot was in extremely severe varus position, and there was single fibula. So I classified this as Weber 7A. Please correct me if I am wrong, sir.
Do you have an MRI or something like this?
Well, I did an MRI. I don't have the slide right now, but it showed a small cartilaginous enlarge proximally.
Yeah, then it's 7A, correctly.
7A, okay, so I'm right. So it was 7A. So first I decided to correct her foot. I decided to bring her foot below the fibula. So after initial castings, I did a soft tissue release and I did a fibular osteotomy and fibular shortening. And then I brought the foot below the fibula and passed an intramedullary nail. So this is at the age of 2. You can see the foot is nicely sitting below the fibula. The cartilaginous enlarge has started ossifying now. At the age of 3, I did this surgery. I cut the fibula here and brought it under the fibula, under the tibia, and then put a nail from foot into the fibula and in the tibia. I did not resect this proximal fibula. I kept it as it is, and later on everything fused, everything ossified. I kept the nail for a while, and this was the position after removal of the nail. The ankle was fine, the foot was in little equinus and adductus, and her knee was developing pretty well. She had full range of movements of the knee. At the age of 6 years, this was the position. Her ankle and foot were very stable. Her knee was stable. She was wearing this orthosis, and she could not only walk, but even could dance with this orthosis. She had developed 6 centimeters of shortening. So at this stage, I decided to lengthen her. So I applied Elizarov fixator. Her fibular proximal end was overgrowing. So I put a screw there to halt the growth. And I did 6 centimeters of lengthening. This child was very cooperative and active throughout the lengthening. At the end of lengthening, I did correct her foot adductors by doing a midfoot osteotomy. So this was the final result. This is the follow-up X-ray actually at the age of 11. She has well-developed knee with full range of movements. Her ankle has some movements, and her foot is plantigrade. That's how it looks. And this is how she's walking. Actually, she can run. She can take part in sports activity as well. So at the age of 11, she has 1.5 centimeters of shortening. So she might need a second lengthening at the skeletal maturity. So that was my first case, sir.
Wonderful. Dr. Weber, you have any comments to make on what Ruta did?
Yeah, Professor Ruta, well done. Yeah,
Thank you, sir.
You see, form follows function, works also in India.
Yeah. Universal.
Okay. Yeah.
Okay.
Okay.
I'm a little bit more aggressive to combine several steps which you have done, but it's completely fine. You did several steps you waited some time to combine the different steps. I would have combined it a little bit more from the beginning, but the result is very good, and those who heal are right.
All right.
Thank you.
Okay, Ruta, you have one more case?
Yes, I do.
Okay, so we can finish that in 5 minutes.
Yeah, so this girl came to me at the age of 6 years. And maybe after listening to Professor Weber, I would have changed my management to booster surgery, but I treated it in a different way that time. She had complete apsidia distally. There was no ankle. And look at the foot. It was in very severe equinus. You can see the soft tissue contractures. The fibula was lying anterior to the foot. So there was presence of cartilaginous enlarge. So I classify it as 3A. And what I did was I did an extensive soft tissue release and tried to correct the equinus and bring the foot anterior below the fibula. And then I again did the same thing. I cut the fibula and transformed it to tibia. I joined it to tibia. I put a nail and the gap which you can see here is not the gap, but a thick cartilaginous enlarge there. So I casted her for a while and everything ossified. Well, she still has equinus, but it's way better than before. At least the talus is articulating with the distal tibia. Then I lengthened her with the technique which I have developed, lengthening over plate. I lengthened her for about 5 centimeters, and that's the final result. And that's how she looks at the age of 16. Now she's 16 years old. And she still has equinus, but that equinus is giving her length. And with that length, now she doesn't have limb-length discrepancy. So she's quite happy. I actually offered her that I would like to correct her equinus, fuse her ankle, and do 2 more lengthenings. She politely refused. She's quite happy with the present situation.
Wonderful. Professor Weber, any comments?
Yeah, this is what I said also in one of my recommendations. You have to respect what the wishes of the patients are, and also everybody who is capable of doing lengthenings want to lengthen that. But if the patient doesn't want, you cannot force them. This is the situation. In the first, as you said, I mean, if there is a cartilaginous Anlage, the best way is to use it in the way I have shown. To bring the cartilaginous Anlage into contact with the joint partner. This is the best way to construct a joint.
And sir, you would have used Lizarov to correct that severe equinus also. The foot was
Yes,
lying posterior.
I'm a fan of the ring fixators. Yeah,
Me
you can
too,
use
actually.
any kind of ring fixators. You can use any kind of hexapod for these things. I always do this because I want to have, number one, optimal stability, and number two, optimal manipulation of the bones and tissues I want to push and pull and distract into a certain way. And this is the best using ring fixators.
Okay. Thank you, sir.
And I also try to even after the first surgery, after first complex of surgery, I try to get the foot into planticat position, and I try to equalize the leg length discrepancy. But this depends also when you get the children. When the children are 18 months or something like this, you can achieve it. And also,
she came late to me, so.
Cherry, can you share by the time?
Yeah. And also when I do the fibula pro tibia operation, first I equalize the telescoping of the fibula. So first a simple soft tissue destruction. And with this soft tissue destruction, I'm not only doing destruction, I also bring the fibula, which is usually more in the posterior part of the thigh, more anteriorly. This has an additional positive effect that later the flexion, when they grow older, is not disturbed by a fibular head which is lying too much posterior to the thigh.
Okay. So I think Dr. Cherry is ready with this case. Cherry, can you share your screen, full screen?
Yeah, I think the screen is shared.
Yeah, just make it full screen.
Yeah, okay. Will do.
Yeah.
Now, this is a story of a long story. It's a 1.5-year-old boy who came with deformity and shortening of the lower limb. Had seen quite a few doctors, got all different opinions. Now, that's a clinical picture. And the diagnosis is pretty obvious. You can see the bump also. That's the X-ray. It's proximal tibial tibia is present. The distal tibia is absent. I did not take an MRI. Those days, the MRI was not readily available. That's other X-rays. That's a hand syndactylization of the middle and ring fingers. And classification, I would put it as Weber type 3B or Jones 2. Am I right, Professor Weber?
Yes.
But if the MRI showed analogue?
Yeah, actually, I didn't think about that, to be honest.
Right. Okay.
Excuse me. Can you go back to the clinical pictures?
Yes. Yeah.
So this if you see this bump here,
yeah,
if they try to pierce out of the skin, they don't have a cartilaginous Anlage.
Okay, that's a sign.
This is already clear. Yeah.
3B. So it's 3B.
3B. Yeah.
Okay. Okay, Cherry, go ahead.
Now, the patient came for surgery at the age of 3.5 years. We did a post-traumatic release. We did a tenotomy of the tender Achilles and all the flexor tendons and tibialis posterior. One thing, interesting thing we found out was the neurovascular bundle was rather anterior. And we did the stage 1 also to distract the angle and bring the fibula down. We found the neurovascular bundle pretty anterior, the posterior neurovascular bundle.
Okay.
And we fixed the frame. The plan was to bring the fibula down with the proximal ring, proximal construct, and correct the equinus. Now that is the frame construct. We did try to bring the fibula down. We brought the fibula down to some extent. But he started developing a deflection contracture. So we managed to get that corrected with in-bed traction by attaching weight to a thread, the bandage tied to a ring. And with good physiotherapy, we managed to get the knee flexion contracture right. But this couldn't correct the Achilles. We removed the fixator. Obviously, we never achieved anything with the Zilizaro, the first stage. So anyway, while removing the fixator, we did the Huntington procedure that is proximally to the tibia and distal to the fibula, the talus. We somehow got ultimately a limb with varus and recurvatum deformity. So, can I go on?
If you want me, I can give you already a comment.
Yes, please do.
Okay, when you do the equalization of the telescoping of the fibula, you have to transfix the knee joint. You have to go to the femur in order to compensate the stress. And look what happened if you only connect it to the tibia. Number one, you are at risk that you get a luxation of the knee joint, which you don't want to have, or you get a contracture of the knee joint, which you don't want to have, or you even get a bending of the fibula. So always transfix the knee joint, put here another frame in, put the isometrical hinge to the knee joint, which you need anyway afterwards for mobilization. And then you can do very easily between the thigh bone and between the foot, the destruction of the soft tissue.
Right.
Then you automatically, and what happens is that the fibula goes down and the foot goes down. And you always have to monitor it, which will be the first. Then you have to lock, for example, usually the fibula comes down first. Then you have to lock this situation and continue with the foot. Yeah, and when this is done, then you can lock it with a fixator. Yeah, so you need to have here 2 rings on the fibula in order to address the single procedure on the foot as well as on the proximal fibula. And as I said, when I do this, I also bring the fibula head more to the front where it belongs to, so it won't disturb the further flexion later.
Okay, nice points. Thank you.
Yeah.
So, Jerry, what happened later?
No, the story goes on. This is the picture. Now we fitted the frame, the orthosis, and this guy started walking. Okay, 2 years later, this is the scene. The foot is inverted. The limb is shortened by that much. That's about 10 centimeters. That's a picture. Varus and recurvatum.
Mm-hmm.
Now we again did the second stage, that is to bring the fibula down and correct the QNS. Tibialize the fibula proximally and distally fuse the fibula to the talus. So that is what we wanted to do. Now this one, we fix the frame according to the right angles. That's why you see the frame bent. And this particular hinge distraction rod is for the correction of the equinus.
Okay.
And we osteotomized the fibula, brought it to the proximally, you can see here with the arrow, and brought it to the tibia, got it fused, and added one more ring, did a mid-fibular osteotomy, and started lengthening. So this is the picture. We put another foot ring to enable the child to walk below the foot ring, and that's quite a lot of length achieved. That's before the frame removal. Everything is okay. 1 year later, again the valgus of the proximal tibia occurred as expected.
Yes.
Now again shortening, 7 centimeters, shortening had increased to 7 centimeters and valgus of the proximal third leg. Now at the age of 9 years, double level lengthening we did. And we ignored the valgus, just tried to get the length. And this at frame removal. Now at 12 years of age, length is equalized. And after frame removal, mild valgus is there, but length is equalized. That's a knee range of motion. Now he's come for the final stage of lengthening, that is 16 years of age, shortening is 5 centimeters. LLD keeps on increasing as expected.
Yes.
That's a knee range of motion. That's at 17 years of age. We did the final correction. Now we had to address the valgus and shortening. And there is a mild valgus, and the cora is at the physis. So we did a with the juxtaarticular hinge. You can see the juxtaarticular hinge. It's above the ring, actually, at the cora. That's osteotomy that's done. That's a valgus correction. And that's just the region consolidated. That's a boy walking with the ring.
Wonderful.
Ring fixator removed. And I don't have the last picture because he hasn't come for the final. I put him on a PGB cast and he hasn't come for the final review. So like the message is, like it involves multiple surgeries and the surgeon should be familiar with the pathoanatomy, principles of limb lengthening, deformity correction, and with the apparatus, whatever apparatus you are using. And counsel the parents and the patient for multiple surgeries.
Wonderful. Very important messages. I'll just ask you one question. At the end of the surgery, at 17 years, were you happy? Two, was the patient happy?
In fact, both of us were happy.
Very good. Then it justifies all the effort. Professor Weber, any comments?
I have a question. You had this tethering effect on the knee area and getting a valgus deformity. When you do the distraction of the soft tissue to bring the fibula head down, are you doing any release to the ligamentum capitis fibulae?
No, I didn't do that, Dr.
Yeah. I highly recommend to do so.
Yeah.
Not only to release the tension from there, for two reasons. Number one, you can get a epiphyseal destruction of the fibula head. It's very weak if you don't do so, or you can get this tethering effect. And what I always do to bring this down, I do a soft tissue release of the ligamentum capitis fibulae as well as of the capsule. I also release incise the capsule so that the fibula head can be pushed down and anteriorly. Then you don't have this tethering effect. If you look at your previous X-rays and previous pictures, you get this valgus deformity, and also it has a severe effect on the lateral growth plate. And so you don't have these problems if you release it. And always, highly recommend, always do a transfixation of the knee joint. You want to protect the tibial anlage, and always integrate the femur, and put the isometrical hinge at the level of the knee joint, and you won't get these problems which occurred in the mid-sequence of the procedures.
Thank you, Professor.
Right. Thank you. So we are nearing 10 o'clock. It's been exactly on time. And thank you, ladies and gentlemen, for that wonderful webinar. Thank you, Professor Weber, for introducing us to the concept of construction and not reconstruction, and how to use what nature has already given us, cartilage anellage, finding out whether the patient has it or doesn't have it, and putting the patient in appropriate class of the disease, as you rightly mentioned, so that we can do the construction by creating joints and making sure that that cartilage anellage can go ahead and make the correct form, provided we give them the function. And you must use tools which you are familiar with, and modular and lightweight for the child, but always talk to the parents and do what is best and reasonable, which they accept and you can manage. Thank you very much, and good night, everyone.
Good night.
Thank you very much. Pleasure was all mine. Have a good evening. Thank you for invitation.
Thank you. Hope to see you soon in India soon.